Hello, everyone. My name is Brian Ung. I'm a recent graduate of University of Maryland School of Pharmacy, and today I'll be talking to you about, from start to finish, an HEOR study. So the goal of today's presentation is to give everyone a brief overview of health economics outcomes research, or commonly referred to as HEOR. And after that brief introduction, we'll go into some important concepts such as study concept development, research design, and analysis of results, and the dissemination and publication of an HEOR study. And so for me to tell you, what is HEOR, or talk about a study, we kind of have to establish a baseline knowledge. So here are 3 different definitions that I've highlighted that I think kind of portray what HEOR gets to. The first one, it's a discipline that is used to complement traditional clinical development information. So again, when we're talking about HEOR, we're not talking about clinical trials. We're talking about research that seeks to add to the evidence already generated by clinical trials. The second definition highlights that HEOR studies can look at different perspectives, such as one from the patient, the healthcare system as a whole, or a certain health plan. And the last definition highlights that HEOR relies on real-world data for the generation of evidence. So data, what are we talking about when we talk about data? So there are a few different types of data sources that HEOR is involved in. The first being electronic health records. So you can imagine information that you see in a patient's chart in Epic. We'll sometimes look at that information, as well as doing chart reviews where patients or providers may have notes about encounters from patients. So we look at that. Administrative claims, so thinking about when you go to the pharmacy, you take a patient's prescription card, you run through the insurance, that claim is captured and recorded by the insurance company, so they get paid. So from that information, we're able to see how much the patient paid, total cost of medication, day supply, treatment histories, those types of things. Patient-reported outcomes, I've listed 3 here. Please take your time to Google these later. I don't want to spend too much in depth, but patient-reported outcomes capture a lot of subjective information, things that maybe perhaps don't have a clinical marker associated with it. So HEOR studies are mostly observational, non-interventional studies that happen retrospectively. Again, we're looking at data or healthcare that has already been administered. The majority of our studies will happen in the post-marketing phase. So here's kind of a screenshot of what data could look like. So you can see there's a column with the number, and then their name, date of birth, and then some level of cost. Now this is just a broad example, but you can imagine that other columns could have drug name, quantity, and so forth. So I went over briefly, what HEOR is, but what do we really do? So 3 buckets that I like to group our activity into are first being patient-reported outcomes, quality of life. So again, subjective information that obviously is important to the patient as they're going through their disease. Comparative cost effectiveness. So with certain diseases, you may have more than one treatment. So it's important to kind of assess the benefits and risks associated with each treatment, as well as the generation from real-world evidence using a lot of the data sources that we went over previously. So now I'll go into a study that I was fortunate to be a part of, real-world treatment outcomes and costs in patients receiving nab-paclitaxel, or AG, as we'll refer to it in this trial, versus FOLFIRINOX, or FFX, in metastatic pancreatic cancer. So first, some background information. You may or may not have received your pancreatic cancer module in pharmacy school, and if you did, it was probably a very short, 1 to 2 lecture type of thing. So we'll review that briefly here. But metastatic pancreatic cancer patients usually live only a few months, and they have limited treatment options. Among the treatment options are nab-paclitaxel, or nab-paclitaxel, the brand name is Abraxane. So that is used in combination with gemcitabine. And another treatment option is FOLFIRINOX, as we mentioned. So both of these treatments, AG and FOLFIRINOX, were compared in separate phase 3 trials against the current standard of care, which is gemcitabine monotherapy. And if we compare, how both these treatments did on their phase 3 trials, we can see numerically FOLFIRINOX has a higher median overall survival at 11 months, but also has a higher incidence of febrile neutropenia and GCSF, growth coagulating stimulating factor, used to treat patients for their febrile neutropenia. So, numerically, it looks like there is some advantage in overall survival for FOLFIRINOX, but some adverse event concerns. But, really, we can't take these comparisons at face value because differences in the selection criteria, inclusion-exclusion criteria, if we take a deeper look into it, patients were healthier in the FOLFIRINOX arm, a little bit younger, and while they're in the Abraxane gemcitabine arm, patients were a little bit more, had greater severity and disability, and were a little bit older. So as a fellow, you're expected to understand the disease background and treatment landscape, and again, with the PharmD knowledge, you should be able to pick that up from the beginning. So study concept. So again, starting here on the left, Celgene, which is my partner fellowship company. We have a branded product called Abraxane, and again, it's used in combination with gemcitabine. And we can imagine, since it is a branded product, the pharmacy cost for it is significantly more expensive than FOLFIRINOX, which, if we look here on the right, FOLFIRINOX is a combination of 5-FU, irinotecan, leucovorin, oxaliplatin. And all of these products have been around for a while. They're not targeted chemotherapy agents, and they are generic. And like we mentioned in the previous slide, there's also a clinical thought that looking at the phase 3 trials that FOLFIRINOX has this survival advantage. So you go into how the study was derived. So like we mentioned earlier, there's no clinical trial comparison head-to-head with Abraxane gemcitabine and FOLFIRINOX. And we could conduct a clinical trial, but clinical trials are going to be very cost prohibitive and very, it's going to take a year or a couple years, whereas a real-world comparison could be quicker and cheaper. So thinking from the Celgene perspective, there's a clear business need to disprove either the economic or clinical thinking that FOLFIRINOX is superior, because if providers and payers think that another product is superior to others, to yours, then you may not see the sales and the usage that you would hope to see. So the study concept is usually derived from the overall business strategic imperatives, and usually the brand leads or researchers will have these studies ideas. So as a fellow, you mostly receive the study concept, you're given parts of these studies, but the goal is that as you get more experience, both in the real world and your academic training, that you'll perhaps in the future be able to derive your own study concepts yourself. So the study timeline may seem a little bit backwards, but we like to start with our publication plan and the due date for that, and then work backwards. So making sure that you have an end goal in mind. So when we do studies, a couple of thoughts are that are we making this a full-length manuscript or paper, or are we just doing a poster presentation? If we're doing a poster presentation, when is the conference happening? When is submission due dates? What's the business need? What's the most effective way to display this information? And after we come up with the publication plan, we'll identify partners on the projects. These studies require a number of different people. Sometimes that's internal. Sometimes that's gauging internal resources. What data do you have access to? Do you have the capabilities to do some of the programming to extract the data you need? External partners are often helpful because they might have more access to data. They may be used to doing these types of comparisons, and we usually contract by project with external partners. So as a fellow, you're expected to collaborate with both internal and external team members, and you're supposed to aid in the publication plan and identify any stakeholders that you need to communicate with. So now we'll go into study design. So we'll take a brief look at a study protocol. As you can see here on the left is kind of the title page, and on the right is the table of contents. Again, I've highlighted the dissemination of results. So, where are we presenting this information and in what way? So as a fellow, you're given the task to draft and/or critique the study protocol, obviously with guidance. So this sometimes is in a Word document like I presented here, but sometimes it can be an Excel document with different sheets. But You're expected to, write the background, the objectives, which we'll go into, and any other parts that are assigned to you. So research objectives, so there's 3 that I want to highlight here. Describing the baseline characteristics, so what patients are going to be included in our study, comparing the treatment patterns. Today we'll focus on time to treatment discontinuation, and compare economic outcomes such as all-cause costs. So again, like I mentioned earlier, study objectives, the fellows should be acutely aware of why such and such is an objective and how it's important to the overall strategy of the study and for the brand. So looking at a brief look at inclusion-exclusion criteria, I don't want to spend too much time on this, but similar to a clinical trial, we're not just going to enroll every patient that is in our database, right? We want, in this case, we want pancreatic cancer patients, and we want patients that are on our therapies. So if you look on the left, inclusion criteria, the one I've highlighted is we require at least 2 non-diagnostic medical claims for pancreatic cancer diagnosis. So this is a way for us to ensure that patients have pancreatic cancer. So we're using claims data, so we don't have, the doctor's diagnosis, but this is the next best thing that we can do. And similar to clinical trials, we want patients making sure that, we have a washout period and they're truly starting our medications fresh and they're not on other medications. So on the right, we have exclusion criteria such as with any claims for recommended chemotherapy during the 60 days prior to the metastatic pancreatic cancer date. So again, this is our equivalent to our washout period. So as a fellow, you're expected to understand the rationale for both the inclusion and exclusion criteria, perhaps add critique, ask why we're doing this information, and obtain the necessary study codes. Going back to the inclusion criteria, we have here in the parentheses this ICD-9 code. This is how we're getting the information, and you may have to search for this information as different codes emerge. So looking at the study time period and outcomes, the first figure is the study design, so we'll take a look at it from left to right. So starting in 2010 to going to 2013, this is our baseline period, which is defined as 6 months prior to our index. And if you look at the index dates, and it highlighted in red, it's initiation of one of our treatments. And I won't go into great detail of the study design, but this gives you a sense of what time period we're looking at patients, when are we enrolling patients, and what is it we're actually assessing. Table 1 is the definition of endpoints. Like I mentioned, we're going to focus on time to treatment discontinuation as well as total cost. And time to treatment discontinuation, why are we using it? What is this time to treatment discontinuation? Well, in oncology, 2 main clinical outcomes are overall survival, which is how long a patient lives for, as well as progression-free survival, which is how long that they're in remission for until they have a relapse. So in claims data, like I mentioned, there are limitations to it. We don't have all of the clinical outcomes we would want because that's just not what is in claims data. But we do have, as we can see, how long patients are on treatment for. So in other words, when are they discontinuing treatment? So this is not a perfect, but it's a proxy for progression-free survival, which will provide us with the clinical marker that we're kind of interested in. And we use claims data in this case because we want to see the overall cost. So as a fellow, you're expected to understand the limitations and strengths of the data source and perhaps create both the study design as well as definition tables as needed for the study protocol. So study design results tables, we mentioned we're looking at time and treatment discontinuation and costs for both treatments. So this is an example of, again, results. We don't have any results at this stage of the study, but we should be able to understand what we want our results to look like in terms of what information are we gathering. So you can see here the N, the number of patients, the mean, median, different types of costs. So as a fellow, again, you're expected to develop these table shells and perhaps communicate the importance of them to your team members, both internally and externally. So how does the study even happen? How do we get from start to finish? So meetings, and more meetings. So meetings can happen with a number of different people. As mentioned earlier, this can be internal people. So people on your HEOR team, and people on your HEOR team who may not have a PharmD background. They may be only Masters of Public Health. They might have a PhD background. You also work a lot with biostatisticians, as well as other departments within your company. But you could also have meetings with external partners. This could be key opinion leaders. Think about the people who are well respected in their industry. They may be writing the clinical guidelines. They may be the lead oncologist at their hospital. But these people are acutely aware of how treatment is handled in their disease state, so they have valuable clinical input in terms of research design and interpretation of the results. As mentioned earlier, you could work with consultants to help have access to the data and complete the studies. And this may happen in different areas of the study. So as a fellow, you're really given the responsibility to set up these meetings. Make sure everyone, you have everyone's availability, and set book a room. You also have to create the meeting agenda. No one likes going to a meeting and everyone sits around and wastes time, and we don't really understand why we're there. So being able to create the meeting agenda, lead some of the discussion points, and obviously be an active participant. You're not just there just to take notes and just sit back, but if you want to be a part of the project, you have to. This is the way you're going to show your values, that you're aware of what the study needs from other people, and you're the one holding everything together. So after we kind of have some of these preliminary meetings and we have our study design and our table shells, then there'll be a waiting out period for our results. Claims data, which we're using in the study, includes sometimes millions of patients, but we only want to look at specific time frame of these patients and a specific patient population. Biostatisticians, either internally or externally, consultants, will do the coding to run the analysis. And sometimes the analysis takes place at different time periods. Depending on the study outcomes you look at, you may have different sets of results, and you will have meetings to kind of dig deeper into the analysis of the results. This may take longer if you're doing something like a survey study, like we mentioned with the patient-reported outcomes. And as a fellow, you're expected to handle more than one study at a time. Your role and responsibility will vary depending on the depending on the stage of the study, but you're expected to monitor the study progress, manage other studies, and communicate with partners as needed. So now the fun part, the study results. So analyzing and interpreting data, the table here on the left is our baseline characteristics. So as we can see here, there are differences in the age, as well as payer type. And I don't want to go too much into biostats, but we want to make sure that the differences that we're seeing in the groups, are they statistically significant or are they not statistically significant? So normally we look at the p-value or the confidence interval to derive this information, but I'll just tell you that the age, as well as the other values bolded that are less than 0.05 are significant. And if you look at our time to treatment discontinuation, and again, this is our imperfect proxy for progression-free survival. We have here the median length and time of treatment discontinuation for both arms, as well as the adjusted hazard ratio. And again, I'll save you the biostats lesson, but this was not statistically significant. So, going back to why we did this study, there was a difference in overall survival that people could just look at numerically that FOLFIRINOX has an advantage. But if we look at here at our time of treatment discontinuation, we see here that there is no significant difference. So this is kind of, attacking that claim of overall survival advantage for FOLFIRINOX. So our other endpoints, such as mean cost of care, table 3. So again, we have rows where we have both arms, and we have the inpatient, outpatient, and pharmacy buckets. And again, I'll save you the biostats, but these differences were not statistically significant. And so again, this was important because, as a branded agent, we have this stigma that Abraxane gemcitabine is going to cost so much more than FOLFIRINOX. But when we did the claims analysis, this was not the case, and they were not consistently significant. So these are some, tools that, as a fellow in HEOR, you need to be aware of. You need to interpret the data, and you need to go back to your epidemiology, your medical evidence, your biostats to kind of gather some of this knowledge. And we wanted to look at costs, right, overall, but we want to also dig a little bit deeper because in the second row, or the third row of the cost table, we saw that the outpatient costs for FOLFIRINOX were higher. So we dug a little bit deeper, and we found in Figure 3 that supportive care was the main driver of that. And if we look at the second to last item, the GCSF usage, we saw that was significantly higher in the FOLFIRINOX arm. So if we go back to the clinical trials, our hypothesis, we already would think that FOLFIRINOX patients have a higher incidence of febrile neutropenia, therefore they have a higher usage of GCSF. And GCSF obviously is a treatment that does cost some sum of money, and there is a significant difference between the two arms. So as the fellow, you're supposed to be able to analyze and interpret the data, communicate this to, again, your internal, external partners, and perhaps question the data if something looks a little bit funny. So our study results, what do we see? What do we conclude from all this? So the results from this analysis indicate that the total cost of care of Abraxane, gemcitabine, and FOLFIRINOX is not different, or it's the same. So again, how does this compare to the phase 3 trials? Again, we wanted to disprove that, and it looks at least from this study that we did. Abraxane, gemcitabine was also associated with lower costs for supportive care. Again, this was driven by the GCSF usage. But also, this was just one study. So further analysis is needed to explore the clinical differences between the two patients. So as a fellow, you're expected to compose the study results, state the limitations, and talk about the conclusion. So publication and dissemination of results. So again, more meetings and emails. This is how things happen in the corporate atmosphere. So discussing the results with the research team, both internally and externally. Preparing for the publication, again, with both sets of partners. This could be composing the abstract, developing the poster, developing the manuscript, and I've listed here some examples of conferences and journals that perhaps we could submit this information to. And as a fellow, again, you're expected to communicate with everyone involved with this study and ensure that submission materials adhere to guidelines, create concise and clear publications. Again, just with the results I've shown you, there's a lot of results here. We don't want to just present everything, but we want to present the main takeaways so that someone looking at the poster can easily, gather the main points and understand what you're trying to say. So writing skills are important in this area of the pharmaceutical industry. So the fun part, the presentation of results. So as a fellow, you're given the opportunity to travel, to go to these disease state conferences, present your findings internally to both internal and external partners, and ensure that the materials are accessible to anyone who needs them at your company. And you may also have the opportunity to present other team members' work. So travel is kind of a plus in this area. So I can send this out, but here is the study poster briefly here. And again, I've taken parts from this poster and included in the study. So kind of summing up, HEOR work with a diverse group of both internal and external stakeholders. Fellows do have a role in nearly every part of an HEOR study, and your participation in each area will continually grow throughout the fellowship. Like I mentioned earlier, study concept is something probably as a first-year fellow you won't be involved too much in. You may be involved more with the study protocol, and you may be more of a passive participant, but as you progress through the fellowship, the goal is that you'll eventually be able to handle some of these advanced techniques. So that was my presentation in a nutshell. I do have some minutes for questions, and I don't know if you, on the other end, if you want to go ahead and type them out, or if you want to go ahead and just speak right now, it's up to you. Okay, I see one question here. For this study, how did you work with external stakeholders to complete the project? So for this particular study, we conducted the, let me see what we did here. We worked with external partners on definitely the publication. I think for this study, it was just the publication strategy. So it was developing the poster, developing the study materials. It was that type of thing.
Hi, everyone. Thank you for coming. If you have any questions, just let me or Brian know. Thank you.